Okay, so this is going to be another round of my lecture that I had given around a month ago at the Endoisms meeting, the first ever Endoisms meeting. The title of the lecture is Problem Solving in Endodontics, and we will discuss some things that we encounter on a daily basis in endodontics and in particular in the endodontic practice. So just a little bit about my background. My name is Yehuda Isseroff. My practice is in New Milford, New Jersey. My endo story really begins in Columbia. I went to Columbia Dental, and then I went to Columbia Endo. I went straight. And in my first month of residency, I discovered TDO. TDO is a practice management software, but really as a resident, the primary benefit to me was the chat, which was basically a discussion forum for endodontists and endo residents. You joined, you paid $50. I don't think I even ever paid. And you had basically had access to the best endodontists in the world, just discussing endodontics on a regular basis. And it's there where I really learned most of what I know today, and was able to develop my philosophy and my practice based on much of that and the mentors that I had gained from TDO. So these are some of my mentors. As a resident, I flew out to visit multiple offices. I flew out to John Cotomy in Colorado and Rahim Karmali, as well as Kirk Faker in New York. I never got to visit Gary Carr, but Gary Carr was one of my primary mentors. Really kind of changed the whole world of endodontics. And I started off working in multiple offices. Many people are familiar with Refuah Health Center in New York, where a lot of people start. I practiced there for a couple of years and knew pretty much right away that I wanted to open my own office. So as I was working there, I kind of incorporated a lot of the lessons that I had learned on TDO and from visiting everyone's offices, and eventually um, around summer of 2019, I decided to start my own practice, and it took around a year and a half between looking for an office space and building it out and buying equipment and so on and so forth. But eventually, I tried to copy Gary Carr as much as possible. I was not successful. It's impossible to copy him, but I got somewhat close. But in another 15 years or something, I'll build another office and I'll try again. So everyone has to have a picture of them working under the microscope. This is me and my assistant's nice little photo shoot that we did for the office. But I really love my setup. As there were some design constraints that were unexpected, but overall, having the assistant side scope, ASI card, and a good photography setup just makes my life so much easier. And it really kind of differentiates this endodontic practice from some others. So we're going to talk a little bit about some problems that we encounter on a regular basis. When I was in dental school, I discovered this book called Problem Solving in Endodontics. I read it pretty much cover to cover. I enjoyed it. I don't know if a lot of the lessons still carry on to this day, but the overall approach is that everything in endodontics can really be broken down into bite-sized problems, and then you could also have bite-sized solutions. So you kind of just take everything as it comes, and you try to conquer it one by one, and eventually you'll come up with a pretty good game plan for pretty much everything that you see in endodontics. Um, Obviously, we're not going to be able to cover everything in a 50-minute lecture, but the goal at the end of the day here is to make your endo slightly easier. So what I'm going to touch on is some anesthesia techniques that I use, some things that we encounter on day-to-day endo, retreatments we'll touch on briefly, and then how to manage large infections. So one thing that I do that is slightly different, a lot of what I've learned is from Sherwin Ching, who's a mentor of mine and also a friend and a referring dentist, probably one of the best dentists in the world, is topical anesthesia. So I do it slightly differently. This is a compounded local topical anesthetic. So typically what you get from a supply store is benzocaine. Benzocaine isn't really that strong. I think studies have shown that it's pretty much a placebo, but I can assure you that this is not placebo because I tried it on myself, and it is pretty strong. It will get the area fairly numb, um, and make injections, especially in more sensitive areas like the maxillary interior, just a lot more comfortable. So the first thing I do is dry the tissue, and then we apply the topical on a Q-tip and let it sit for 2 minutes. I use these sand timers in my operatory because I don't have the patience or the ability to apparently know when 2 minutes is, and I'm certainly not going to count to 120. You don't want to let it sit for too long because it can cause some tissue sloughing because it is pretty strong. If you look at the ingredients here, it's a combination of 3 different anesthetics and vasoconstrictor. You have to custom order it from a compound pharmacy. The one that I use, there may be a couple out there, but I think the most popular one and the one that I use is Park Compounding Pharmacy. You can Google it. As you see, it's expensive. It's not cheap, but it will last you for a little while. And in my practice, at least, it does make a difference. I get patients, saying that they really didn't feel anything at all. So I would say give it a shot and see how you like it. But it definitely is something that we constantly reorder. We're not going back to benzocaine anytime soon. In terms of actual anesthetics, injectable anesthetics, I like to use Citronus as my first injection in. It comes in 2 different flavors. The plain, which doesn't have epinephrine, and the Citronus Forte, which is just a great name to say, Forte. I like saying it. Maybe that's why I use it. I don't know. But for the Citronus Forte is 1 to 200,000 epinephrine. So the reason why I like Citronus in general is studies have shown that it will have a slightly longer pulpal anesthesia. Prilocaine is slightly longer effect than lidocaine, bupivacaine, and articaine, as you can see in this chart over here. I don't know what the reason is for that, and especially I don't know what the reason was 4% because lidocaine typically comes in 2%, prilocaine and articaine are 4%. They seem to have pretty similar chemical structures, so I'm not sure exactly why one is 4% as a standard and one is 2% as a standard. But if it's the same volume that you're injecting, then if there's no difference, it should kind of have a greater onset and a greater effect. I use Citronus Forte for my first block. Patients who are allergic to epi, I kind of just use it on them anyway because it's a lower amount of epinephrine. Maybe it burns a little less on the way in. I think sometimes people say that epinephrine is what causes the stinging. I like Citronus plain for anteriors because the plain goes in a little bit more comfortably. So I'll leave that topical on for 2 minutes. And what I like to use in terms of a needle is a Septoject Evolution. They have a double bevel tip. And you kind of just use the extra short, which is this purple one over here. Just go use a Citronus plane and you just go into the tissue and usually just deposit like a half a carpule, let that sit, and they really don't feel that much. But typically the maxillary interior, because the tissue is so tight, is the most painful area to inject. But really, especially in kids, you don't want to start off on the wrong foot. If you can gain their trust with the anesthesia, the rest of the procedure usually goes a little bit smoother. My second anesthetic after I've given the Citronus is typically Septo, Articaine, and then sometimes if it's a really hot tooth, I use Marcaine. And then on some patients who really have heart disease, I will use anesthesia, bupivacaine, or Citronus plain only. This has been a big game changer for me. I also learned this from Sharon Cheng. PDL injections have been great and are great for teeth that are hot. You can spend all day and waste half the appointment time trying to get a hot lower molar numb with blocks, but you'll realize soon after 30, 45 minutes that you're not even touching it. You're not even affecting it at all. But you can go in with a good PDL injection and within instantaneously, sometimes it could just go numb. So I use it pretty much every hot lower molar, sometimes even on hot upper molars. And then it works so effectively that I just started using. Yeah, it works so effectively that I just started using it on pretty much every vital lower molar. I'll block, I'll give a little local infiltration around the tooth, wait a few minutes, and then just go in with the PDLs. And then pretty much that after all that's said and done, it's 5-10 minutes into it, and I just check the tooth with some cold, and if they're numb, I'll just go ahead and get started. Um, and it just moves things along a lot quicker. So if you're trying to get through the day, you're falling behind, it's a great technique to have. I also like to use it for nervous patients. I used to use this Entrolig. It's scary looking. It looks like a gun. So for nervous patients, you don't want to come out with a gun. I can't get you numb. So it produces so much pressure that it could actually break the local anesthetic cartridge inside and shatter the glass. So nothing really builds up trust like shattering glass inside of a patient's mouth before you attempt to work on their hot tooth. Sherwin introduced me to the Paraject, which is just so much better. It's smaller, it's less scary, and it seems to work better. It produces the right amount of pressure, but not too much pressure. And for this, I like to use Lido 1 to 100,000 epi, and again the Septiject Evolution extra short needle, which is what I had shown you before. And this is also slightly cheaper. It's blocked out by the video here, but it's in the 300s. But I love them so much that I just bought a few of them. I never wanted to run out. So this is where you kind of go first for a PDL injection. I like going right in the furca. Sherwin likes to go at the interproximals. I haven't found many issues with tissue sloughing. I used to have more issues with tissue sloughing when it was septo, but with Lido, I haven't found that much, knock on wood. So the basic technique is you want to put downward pressure. You actually have to kind of push the needle in with your other hand, because if it's not locking in, so to speak, it's just going to come right out of the sulcus. It's not really going to do anything. So I'll go start off doing that in the furca. I'll give a few clicks there. The most important thing is you want back pressure. If you're not getting back pressure, you're not doing anything. So you really have to apply some force. And once you get the force and the back pressure, you should start to see the tissue blanching. And then if it's a really hot tooth, I'll just keep on clicking. Just, a few clicks, 5 clicks in one spot, then I'll move to another spot around the tooth, go to the lingual. Everyone has these teeth in their practices that just don't get numb. And honestly, it's really cut them down. The incidence of not being able to get a patient numb after I've incorporated this technique. So this is a little video of me giving a PDL injection with the Paraject. This was a broken down number 30. You can see here I'm going right into the furca, and I'm trying to get good back pressure by pushing apically with the needle. And then you can see click. You can see it's not, if you're instantaneously getting the click, you're not doing anything. Your hand should shake a little bit. That's how hard you should be pushing. And then you'll know pretty much immediately that you can test whether the tooth is numb. I remember one patient who had such a hot tooth they couldn't even breathe in cold air, and it was so painful that when my assistant was suctioning with the saliva ejector, it was just too painful for her. And then, but as soon as I put the PDL in and I got the right spot, she's like, "Wow, the pain's gone. The saliva ejector didn't bother her anymore." That's how fast it can work, and often does. So if you haven't tried it yet, you should definitely get your hands on one. Now, again, I mentioned before the complications. This is actually a friend of a friend. I had done a root canal on her number 30, and she ended up with some tissue sloughing. This was when I was still using the Intralig, and I was also still using Septo. I'm not sure if one or the other. Probably the Intralig is just too much pressure. But this can happen. You just got to reassure the patient. The tissue will grow back. Just keep it clean, and it did grow back. But around a couple times a year, even with the best techniques, you still can't get patients fully numb. And don't torture yourself. Don't torture your patient by trying to get the whole endo done in one visit. Typically, I'll just go in at a faster RPM with my rotary files. Just try to remove as much tissue as you can. Don't try to futz around getting working lens or trying to get patency, because the cases where every millimeter patient's jumping. It's just not worth it. Just irrigate, get as much tissue as you can, put in calcium hydroxide, and then wait a few weeks. And inevitably, by the second visit, the rest of the tissue has kind of died, and things are much easier to get numb and to work on, and everyone kind of appreciates it. And typically, the patient will be out of pain by the next day in those cases anyway. So you're the hero. But if you try to pressure yourself to finish in these cases in one visit, it ends up being torture for an hour or whatever it is. So I'm not a wine connoisseur, but I think of myself as a little bit of a cavet connoisseur. We're going to move on to temporary fillings. Cavet makes a wine unrelated, as far as I'm concerned, to the temporary filling. They say it's America's favorite Italian wine. I think cavet is America's favorite temporary filling. It's my favorite temporary filling, at least. I learned last year for the first time that there's actually 3 different flavors of cavet. There is cavet pink, cavet W, and cavet gray. I don't use white anymore. I used to exclusively use this, but it's kind of the middle ground, like Papa Bear, Mama Bear. Cavet pink is for really sturdy temporary filling. It will last the longest. I don't know why they don't say it on the label itself, but if you look at the if you look on the 3M's website or on your supply, wherever you get cavet from, it will kind of explain the differences here. So it's a harder set. It will last longer. I use it for smaller temporaries, like single surfaces. And again, this is if you're restoring teeth, or if you want to make the general dentist life, your restorative dentist life, a little bit easier. Gray cavet I'll use for bigger temporaries because it's much easier to remove. So when it's time to actually restore the tooth, you don't want to be kind of picking and drilling at pink cavet. It tends to kind of stick. Pink cavet tends to stick everywhere, and it's a little bit of a pain to remove. Cavet G, gray cavet, is just much easier, but it won't last as long. So you want to make sure that you're getting patients back in a more timely fashion to restore those teeth. I do use long-term temporaries in some instances. These cases are what we call production killer practice builders, because no, they're not super profitable, but they are for, kind of differentiate your practice. It can differentiate your practice from other practices where they're not willing to kind of put in the time and effort to save teeth that are really compromised. So I use long-term temporaries in cases that have large or diffuse lesions. Typically, they're very symptomatic, or sometimes even where they're asymptomatic, when you can't really know with a span of a few weeks whether things are healing or not. And also, if they're being planned for a bridge or an implant next door, you want to make sure that things are healing before you give the green light to the surgeon or the general dentist to move on with their restorative treatment plan. So what I'll do is I'll typically restore the interproximals permanently if they are previously unrestored. I'll get the endo started, clean out everything, and then I'll temporize with a sponge. Typically use a sponge, some layer of pink cavet, and then I'll use 2 to 3 millimeters of unbonded composite. I like to use Opal Dam in most cases because it's so easy kind of to differentiate between that and regular tooth structure. And then you wait 3 months. I typically have 3 months. The reason I choose 3 months is because it gives you the opportunity to kind of change out the calcium hydroxide if you need to. And it's long enough that you can take a new CBCT and compare them side by side. If you take a new CBCT after a few weeks, you may see something, you may not. It's a little hard to kind of tell in that quick. But 3 months, you can usually see which direction these cases are going. So this is a quick example of a long-term temporary. This is a young patient. The endo was done by another endodontist in the area. It was done many years ago. He's asymptomatic, but a large lucency was noted on his hygiene exam. You could see that the distal is broken down, not the best restoration here. So, you know, I don't do these in one visit. I don't, and I wouldn't even feel comfortable many times doing it in two visits, because if it's asymptomatic, how are we supposed to know that things are healing? Especially in younger kids where you're doing a retreat, the canals are already really large and you have to kind of go in and get everything cleaned out. These cases, I just feel more comfortable putting in a long-term temporary so that I can see bone healing before I complete the case. Here's a CBCT. You can see it's a large lesion extending all the way from the mesial to the distal. And this is the pre-op restoration. It was leaking pretty much everywhere. So the first thing I did was clean out the old restoration. There was some decay on 18 that you can see over here, so I just restored that with a direct approach. Um, and I built up the interproximal because I don't want to leave cavit interproximally for 3 months. That's a recipe for a disaster. Um, so here you can see I got everything cleaned out. I use a Garrison ring here. I typically use Palodin now, but this was a little bit of an older case. And here I built up the distal wall with composite, and now the rest of it is much easier. You know, the advantage of restoring the interproximal is not just that you don't have to leave a temporary filling in there for 3 months, but also it makes the endo easier. You're not worried about hypochlorite spilling out or inflaming the gingiva and causing an issue. Making things more difficult to restore. So then I got into the old root canal. Didn't look like the root canal was very well done. There was some old pulpal debris still present in the chamber. There was a missed mid-mesial. So here's what it looks like. Here's what things look like after the first visit. You can see this is the pre-op. I restored the interproximal, put in calcium hydroxide and a temporary filling. I changed out the calcium hydroxide once, and then we got him into the cavit and opal dam for a long-term temporary. So he came in 3.5 months later, and from the PA, it looked already like things were healing. Things were going in the right direction, so we decided to complete the case. And then the scan also showed things healing up between the mesial distal roots and bone filling up very nicely. So this is the final restoration. Everything is done, with rubber dam isolation. And eventually the tooth may need a crown, but my goal for these patients, especially younger patients, is to restore things to proper form, function, and contours so that they can maintain their tooth and just let things heal for as long as possible before they need an indirect restoration. But definitely things are going in the right direction here. I expect this is fully healed by now. This case is already a couple of years old. So how do you remove temporaries? I know it sounds like a kind of a stupid question to ask, but when you're doing a number of 2-visit cases like I do, I probably around 50%, maybe slightly less, 40% of my practice is multi-visit. I just don't really like using burrs to remove cavit or temporary fillings. It just becomes messy. It's tedious, and you end up inevitably removing more tooth structure every time you remove a temporary. So I early on started using ultrasonics to remove temporaries. What I like about it is that it's much cleaner. It's easy. You don't need to use water. It will just kind of cause the using the ultrasonic dry will kind of just demolish the cavit, and it won't really, as long as you're careful and your assistant is in there cleaning things out with you, you don't really risk destroying any tooth structure like you would with a burr. So you can get ultrasonics, and this is like an endocart that I used to use when I was jumping around offices. I used to keep it on there. They're a little bit expensive, but if you're doing microscopic endodontics, you need an ultrasonic anyway. So this is a good one to get. I happened to get one on eBay for a little bit cheaper. And I like the Pro ultrasonic tips. There's Endo 1, which has a ball on the tip. Just kind of makes things very easy, good visualization while you're getting down. I mean, there's nothing worse than removing cavit that's just been placed a little too deep. You kind of can't see where you are, and you just want to get back in and get the job done. So the ultrasonic just makes things a lot easier. Obviously, if you're working without water, you want to make sure that this is a devitalized tooth or one that will be devitalized. Um, and then I can typically go in with a thin taper diamond after all that's done before I do my restorative. So this is a little quick video just showing how easy it is and how clean it is to clean out this is gray cavit with an ultrasonic. It just kind of melts. It's actually kind of satisfying. And taking out some Teflon, going in with a Strapco and just rinsing out the residue, and that the whole process takes a minute or less. Just makes things really quick and easy and clean. So now we're going to move on to large infections. We see a lot of these. I see a lot of these. For some reason, people don't want to tackle these, but I do. So the first thing you want to do in these cases that are just draining nonstop, and I'm sure everyone sees these sometimes, is you want to try to get as much fluid removed from underneath the tooth as possible before you move on. So what I'll use is a surgical aspirator tip, and then I'll put one of these clear calcium hydroxide or sealer tips on top of them. And you can stick that all the way down deep into the canal. It creates almost like a vacuum, and you'll start just seeing the fluid really come out much quicker than if you were to just let it drain out on its own. So I use that on pretty much every case that is draining. My assistants know to kind of set that up anytime they start seeing pus coming out. So let's say and sometimes you need to let that work for a few minutes, but let's say you're still a few minutes in and it's still not drying. So what do you do then? So a lot of people will leave teeth open. I used to do that. The problem is it's gross. First and foremost, to remove salad, that's stuck in an MB2 or something. I don't know. I'll deal with pus every day, but I just don't like digging out food with a spoon excavator. When you leave a tooth open, you can't really complete it in 2 visits. So you have to do 3 visits at least. You need to get that back in to clean it out and temporize properly. So you're adding chair time. And then many times when I used to leave teeth open, I would wait a few days, get them back, and it was still draining, or they were still symptomatic. And sometimes you would try to clean things out, temporize it, and then they would call again, the pain's back. So that was an issue. And then finally, a lot of these patients, if a patient leaves your practice and doesn't come back or delays coming back, if they have an open tooth, well, by the time you get back in there, the whole chamber is decayed out, and then that's not the place where you want to have decay. So ideally, you want to temporize teeth the first time. So what I do is I use a calcium hydroxide powder. I believe I learned this technique from Stephen Delgado. And the advantage of using calcium hydroxide powder is that you can temporize right away. And I'd say the vast majority of the time, they're fine, patients are fine, and by the time they come back for the second visit, things have healed up, they're not draining anymore, and you're good to go. So you cut out that other visit. It's surprisingly predictable. I think because it's kind of packing in the antibiotic and it's not getting washed out. I think that allows you to temporize things and allow the area to heal. Whereas if you're using paste, you just see the paste kind of rising up with the pus, and you're like, what am I even doing? So I'll show a little case here. This is a very broken down, very heroic tooth, but the patient wanted to try and save it anyway. She was missing a few other teeth. So this is a case that I saw the x-ray in the previous slide. Really, really infected, large lesion. And here I'm using a gutta-percha point to try and compress the calcium hydroxide powder into the canal, but you could see from the distal buccal that it started swelling up again. So here I'm going back into my clear tip, and you can see all the drainage coming from the distal buccal. And the key with this technique, with the calcium hydroxide, you just got to keep packing. Once you get the fluid a little bit under control, just keep on packing, because eventually it will turn into like a packed powder. You don't want a slurry that's gonna like kind of wash out. You want it to be fully compressed. So I use endo pluggers, use gutta-percha, sometimes paper points to get the calcium hydroxide as deep as possible, the powder as deep as possible. Now, sometimes we get these large lesions, you're not really sure what to do. So, this was one of those cases I saw back in 2020 in a different practice. So, unfortunately, I don't have access to the scan. This patient had a recent endo around a year ago. The endo looked fine, obviously a little bit of an extrusion there, but she just had this massive lesion. On the scan, it was through and through and through. In other words, it went to her palate, and then it also went up to her nasal sinus. So not the type of case that I'm so excited to do an apical on. She had a firm swelling and she had symptoms. And this type of case, I just don't see retreating as really bringing anything to the table. Most likely, it's going to need some sort of surgical intervention. So, she was scheduled just for a consultation that day, and I wasn't sure what to do. So, what I said was, let me get rid of your symptoms at least. Let me try to get things under control a little bit, and then we could always reevaluate later. So what I did was I got her really nice and numb, and I did an IND, but what I did was I kind of aggressively went in with like a spoon excavator and just tried to get in as much as I could. And a lot came out. A lot came out. And then I followed up with her in a month or so. She came back in, the swelling was completely gone, and she was feeling better. And within a month, you're really not going to know from 2D, a 2D X-ray, whether things are healing or not. But I was encouraged to say, let's see if we can get things healing up, then maybe we can avoid an apical, or maybe we can just have an easier time with an apical if we don't have to go up to her nose. Then she came back a few months later, and things are looking pretty good. Her swelling was still gone, her pain was gone. Again, 2D, you're not really going to know for sure, but it certainly didn't look bigger, and to my eyes, it looked slightly smaller. I subsequently left the practice, start my own. But the owner of the practice sent me a year follow-up showing nice healing without any apical, without any retreatment, just an aggressive IND. So I jokingly termed this the lazy man's apical because there's no sutures, there's no flap, there's no bone graft, there's no resection. You're kind of just going in there and just kind of going to town on the apical lesion. And surprisingly, it works a lot of the time. It doesn't always work, but it works. It works in some cases. And what I started using is it as an adjunct to retreatment, or as an adjunct on cases that are not recovering or feeling the way that they should be. So here's another case where I did a lazy man's apical. I started this case as just a regular root canal. Patient had discomfort primarily to palpation above the root apex of number 4. Access through the crown. I completed the case in one visit. I got some nice apical anatomy. But she came back 3 weeks later and she still was having discomfort. In the same spot. She said it hasn't really gotten that much better. So I decided to do a lazy man's apical here to see if we can get things just healing on its own. Maybe things are just stuck inside the apical tissues. They're not going where they need to go. So I got her nice and numb, went in with a blade, and I was able to remove a granuloma just from the apical itself, just from the lazy man's apical itself. And then sure enough, she comes back in 10 months and things have healed up really nicely. She's asymptomatic. I took a new scan because she needed a different tooth treated, and really nice healing on that number 4. So this is a case that I probably would have retreated for no charge, or maybe even done an apical at no charge, but all I need to do is really just get her nice and numb and get everything that was stuck inside there out. So I was able to avoid more chair time, more more procedures just by doing something fairly simple like the lazy man's apical. Here's another interesting case. This patient had this treatment done originally by a different endodontist. There was a missed MB2 around the mesial buccal. At the first visit, I went in, located the MB2, got a nice drainage. That's the missed MB2. This one even had an MB3. There was a whole lot going on there. And put in calcium hydroxide. At this point, I don't think I was using calcium hydroxide powder yet, but I put in calcium hydroxide. 3 weeks later, she came back and she was better, but now the pain was back. So I cleaned it out again, and it was more drainage, and I temporized, and then she was better, but then she came back a few weeks later. It's still bothering me. And I was expecting that it was still going to drain if I were to go in there again. So previously I would have done what's called a pack and whack, where you pack the case and then you go in and you do an apical at the same visit. But I don't like doing apicals if I can avoid it, especially on molars, especially on number 3 where it's the wrong side. So what I did was I got her really nice and numb, and then I went in before I went into the tooth. I went in and did a lazy man's apical. And there was no swelling here, but I knew that she had palpation sensitivity. So I got her nice and numb and just went to town on the apical tissue. So I was able to get drainage through the gums. And here I'm sticking a clear tip into the hole that I made. And I'm getting drainage through that. That's another little tip that you can use. And then I went back inside the tooth. It was dry. I cleaned it out and I sealed it up. I took a post-op scan just showing kind of where the 3 MBs were going. It's pretty cool anatomy. And then I sealed it up. And now you can see she came back for a 6-month recall and everything was healed up. She was feeling great, asymptomatic. She was asymptomatic after I completed the case. So again, lazy man's apical allows you in some cases to avoid doing a full apical. I'd rather not. And it helps move the healing process a little bit farther along than just a typical redress or recleaning. So this is the final case I'll show. This patient presented with a necrotic number 9 with a very large lesion, large swelling. You can see here how big that is. It's like a grape. This is one of those patients, super nice guy, but it sounded like his wife made all the calls and he didn't even realize he was swollen there. But it was found on a hygiene exam. And he was sent right over to me to have it addressed. So I opened up the tooth, placed calcium hydroxide. I went in, did a lazy man's apical on the swelling, and then waited a few weeks. The swelling had gone down, and then I completed the case. A bit of an extrusion there on the BC sealer, but it happens. And came back at 3 months, and the swelling was back, and we kind of knew. Anytime I do a lazy man's apical or I do a case on a large lesion like this, I typically will warn the patient that we may need a full apical because you don't want to surprise them. So you kind of just paint the worst case scenario at the first visit, and then if you are able to avoid those things, then you're the hero. But if you have to do the apical, then at least you could say, "I told you so." We ended up having to do an apical in this case, even though I had drained it out. And so this is what I call the disappointed man's apical, where you've done a lazy man's apical, but then you end up having to do a full apical anyway. So here I flap the area open. You can see the very large lesion there, just kind of getting that all degranulated. I cut off the apex. I didn't think I needed to do a retro prep or retrofill here because everything was kind of clean in there. It was just a cyst, bone graft membrane, sutures, and things are looking good at 6 months. So we're going to move on to some rapid fire tips and tricks that you can incorporate on your regular practice day to day. The first thing that I like to discuss is cold testing. I think a lot of people get this wrong. They were taught the wrong way in dental school, because I get patients referred with a situation like this where you have multiple teeth that could be contenders, and they have cold sensitivity, and you're not really sure which one is the culprit. So what I like to do is work your way up. You don't want to put endo-ice on a pulpitis tooth. That's going to cause the patient to hate you, because it will cause a lot of pain. And that's the cases that come to me when they see the endo-ice on my table. They're saying, "Oh, no, don't do that. The other dentist did that and it killed." So you want to work your way up slowly. So I start with a low pressure straw comb, just kind of going tooth by tooth, just seeing if there's a hypersensitive response in one of them. And you can usually tell which one is which is causing the issue based on that. If that's not producing enough of a response, you can work your way up to more air. And then if you have to use endo-ice, just use the tiniest of tabs. And then sometimes you'll be able to see the response, the difference between that and a control tooth, just from a tiny tab with the endo-ice. If you're not doing that, if you're not getting a response from that, then you may have to hold it onto the tooth for a second or two, and until they react. If the tooth is going necrotic, a lot of times will be a delayed response, and then they'll hold their face in pain because the nerve is already in the process of dying and it needs more time to kind of react. So that can also be a useful tool to figure out which is the offending tooth. The next tip that I like to use is bite block. I don't ask permission to put bite blocks in my patient's mouth. I don't think that is effective because most patients will say no. I've seen people say, "Can I put this bite block in your mouth to help you stay open?" That's they're gonna get a no response. So what I do is I just it's one of my favorite quotes is it's sometimes easier to ask for forgiveness than it is to ask for permission. So what I'll do is I just attach the saliva ejector into the bite block, and then I tell the patient, we're going to put a little pillow in your mouth for you to rest your teeth on. And how much nicer does that sound than saying, I'm going to put this, can I put this bite block, in your mouth? It's a little bit more intrusive, a little bit scary. So when you put this saliva ejector, fits right in between the notch, and you put it inside, it kind of helps everything stay right in place. I remember I was watching an endodontist once work, and he didn't use a saliva ejector, and I was like, oh, that's interesting, no saliva ejector. And then sure enough, like 20 minutes in, the patient just coughs up like a mouthful of saliva all everywhere. It was gross. So that's why I always use a saliva ejector unless the patient is really super sensitive. And I like to get all these things in place before I put the rubber dam on. You don't want to put the rubber dam on, then kind of stretch it open to get the bite block in. So get everything set up, the apex locator hook, and the bite block before you get the rubber dam on. That's a happy patient using the saliva ejector in the bite block technique. The second thing that I absolutely try to get everyone on board with is using using the wires, the lines on the grooves of the rotary files and hand files, as opposed to using a rubber stopper. If you're working on 4 canals and you have to go and adjust the rubber stopper every time, it's a lot of wasted minutes. There's no reason. You just need to pay a little bit more. You need to pay a little bit more to get hand files that have this. But once you get into the system and the habit of getting your working lengths using these files, it makes your life so much easier because you never have to use a rubber stopper again unless it's a really short route or really long route. Another advantage to this is that if you're working through a crown and you have a smaller access, especially if you have a smaller access, where's your rubber stopper going to go to? It's going to go to a cusp. You're gonna get somewhere on an incline here. These are areas that are really hard to reproduce. And you don't want to be dragging your file halfway across the tooth to get your rotary in because you want to hit your working length for your rubber stopper. That's going to cause unnecessary stress on the file and it can cause things to break. If you're using a wire, the beauty is that you can basically get to the edge of your access on the crown, no matter where it is, and you'll know exactly what your working length is just from that wire. So you're saving time on your measurements. You're saving broken files. You're just creating a much more streamlined system, and it works a lot smoother. This is something that I think everyone should try. I know a lot of people use these file holders to get their rotary files into like a second molar. I just don't think it's necessary. I use the file grabber from I don't know if that's the official name, but the file grabber from the Root CX2. It will automatically hold your file in the perfect spot, and you kind of just curve the file right into where you need to go. A lot of apex locators don't have this exact setup, so that's why I like the Root CX for this reason. But it basically does away with the need to use a different instrument. And now, as soon as you get the file in, you're already able to take your working length. You don't have to futz around by getting that onto the tooth as well. So this is a case where that was done by an endodontist. I think they filled it. I think they got like 4 millimeters short or something. Don't cut corners. I like taking working length shots on probably like 90% of my cases. However, you do want to cut corners on your rubber dam. The reason why is because if you are taking a cone shot and you're taking off the frame, I use a metal frame. I don't like the plastic frames. So if you're taking off the frame, especially if you're working on a second molar, a lot of times you lose your orientation. You don't know where things go when it's time to put the frame back on. But if you cut a corner of the rubber dam, you'll always know that that corner is the lower left. That's the corner that we cut. Um, and you don't want to be trying to figure out your rubber dam like a Rubik's cube. The patient's wondering what's taking so long. So if you cut the corner, you know right away where your frame needs to go, and it makes life a lot easier. And again, more happy patients. So I get a lot of questions on how to do build-ups for smaller spaces, post cementing posts. So this is a case that I got back where I had temporized, which I don't do much anymore of. But you could see is this terrible? No, but I think there's room for improvement. So you could see the fiber post that was used was a non-tapered and parallel post, so it doesn't really fit the canal space very well. And there's also multiple voids because they probably weren't using the correct materials and the correct equipment to fill the post space. So this is what I use in my practice. I like to use the Unicore and the DT light posts. These are tapered fiber posts. They come with matching drills, and the Unicore makes the size 0, which is, I believe, one of the most conservative fiber posts, which I use for as an accessory post or a smaller post space, smaller tooth, like a lower anterior. You don't want to start drilling out a lower anterior post space with even to fit a DT light 0.5, it's just too big. So I stock both of these, and that will pretty much fit in every case, and they're appropriate for every case. I've used a number of different build-up materials. I use Luxacore, Build It, Fluorocore, and Anchor. Anchor is my favorite by far. I don't stock anything else. Anchor comes in 2 flavors. It comes in A2 and white. I will use A2 for anteriors or cases that I believe may have some show through, and white for molars if I know the dentist knows that it's not temporary filling material. That happened once. So the way that I work it, some people mix the Anchor on a slab or on a paper, on a pad, and then load it up into the Mark II tips, the AccuDose needle tubes. That wastes time and can often introduce air bubbles. So yes, it's a little wasteful to use the tip, but that's just more predictable in my hand. So I'll run it through the tip that is provided by Anchor, by Apex. And then I'll dispense it into the aqua or orange tips, put the stopper in, and then snap it into the Mark II. And now you are able to do your build up or cement your post in a very accurate and predictable way. So I'll use the aqua for smaller accesses and like a lower anterior where I kind of just drop in, or I'll also use that for post cementation. And then I'll use these for bigger build-ups. And sometimes I'll have my assistants load both because this is really hard to get to push out material. So if you're doing a large build-up, your thumb is not going to be very happy doing that. So I'll do this for the initial part, and then I'll move on to the orange. So yes, a little wasteful, but it gets the job done. So this is a small video made just showing how it's done. You can see I'm using the materials provided by Anchor and then injecting into orange Centrix tube. Put the plugger in. Snap it into the Mark II. And the tip. And you're ready to go. So this is a post cementation. So I'm going in with the aqua tip you can see here, going into the palatal canal, and then I'll just try to extend the buildup material into the other orifices. But you don't want to do too much because you don't want to lose your spot of where the post needs to go. Been there, done that. So you're going to see here now I'm going in with a fiber post. Everything has been bonded already. And just like in Happy Gilmore, you want to try to tap it in. Just tap it in. But you can see it's not going to where it needs to go, so I have to redirect. Gotta do this quickly. And now I can tap it in. Just tap it in right to where it needs to go. So if it's a smaller space and let's say you're doing a post through a crown, you can oftentimes lose sight of where you need to go. So it's a very tricky balance of getting the core build-up material into all the nooks and crannies, but at the same time getting the post in time, um, and to the spot where it needs to be placed. And after I do that, then I'll use a paste like a Ceramage to restore the rest of the access. So this is a quick retreatment workflow. A lot of people struggle with what to use during retreatment. I use a whole different lots of different stuff for retreatment. I'm not even going to touch on post removal. Um, Retreatments can be really easy, but they can also be the bane of your existence and want you to make you become an accountant. I like the car ultrasonic tips for removing composite, getting things removed around posts. And then I'll use a B&L alpha to kind of melt the initial gutta percha in the orifice. And then these are my favorite retreat files, my favorite orifice openers. They're not heat treated, which I like because they don't break, and they're more aggressive. And I'll spin these at around 700 to 1,000 RPM, depending on how stiff the gutta percha is. Don't say chloroform, we say C-form, no one knows. But you dribble that in just above the orifices, and then you can go back and use the retrieve files. Once I have the coronal gutta percha out, I'll replenish the C-form again and again. You always want to keep kind of a little bit of a pool in there. Not a pool, but a reservoir of chloroform in there so that you can remove the rest of the gutta percha. I like the DC tapers from SS White at 700 RPM. I'll take them to around 2 millimeters short of my estimated working length. And then once I have my estimated working length, I'll go in with an XP3D at 1,000 RPM or 700 RPM. And this kind of acts like a cotton candy effect to kind of whip up all of the gutta percha around the walls. Finally, once that's out, I'll replenish with chloroform again and then go in with a 15K or 10C hand files and just try to poke my way to patency. And then one of the tricks that I picked up fairly recently is to use paper points at the end of the cleaning phase to try to wick up all the residual chloroform at the apex, because a lot of times it's hard to do that at once everything is cleaned out from the coronal and middle thirds. So paper points with chloroform, very effective way at removing the residual gutta percha and in the apical third. That's pretty much all we had for that 50-minute slot. Hopefully we'll have more material coming at future Endoisms meetings. If you're interested in joining Endoisms, just feel free to reach out to me. This is my office in New Milford. You're welcome to stop by, come and visit. The door is always open. Thank you again. And if you have any questions or comments, feel free to leave them in the comment section below.